Hello, I'm Winfried Zeppenfeld from Flensburg, Germany. I'm a certified member of the European Society of Endodontology. It has long been known that root canals are very complex structures which are absolutely impossible to clean completely with files. I've been working with VDW as a consultant on the product called Eddy. Eddy is a unique tool made from polyamide compound which is driven by the power of an air scaler. I would like to share with you how the application of sonic energy or sonication has evolved in my practice and what influence it has on endodontics on a daily basis.
In this little video trailer, you can see how Eddy works. You can see debris in a lower C-shaped molar. There's a lot of debris in it. Eddy is used to activate sodium hypochlorite to clean the root canal and get all of the debris out. Eddy is a little polyamide tip driven by the power of an air scaler. It has long been known that root canals are very complex structures and that it is absolutely impossible to clean them with just our shaping instruments, as you can see from this old publication from the early 1900s. With modern methods, we can illustrate the complexity of root canal systems, for instance, with micro-CBCT, but the result is still the same. It is not possible to clean such a complex system mechanically. The same can be shown when you look at transparent teeth. These teeth were done by a friend of mine, Holm Reuver, and you can see that the file in those canals has no chance to clean the canal completely. There is a very famous publication by Nair et al., which really shocked me when I saw it at first. They did a root canal treatment in a single visit, prepared the canal, disinfected it with a syringe, and did the root canal filling followed immediately by an apicoectomy. Then the resected root tips were examined under a microscope to see how well they had done. The results were quite frustrating. If you look at this slide, you can see when the magnification increases, there are bacteria all over the place, although they really tried to do a good job to disinfect that root canal system. Besides, there is another problem. Not only are we incapable to clean the root canal system completely, we also shove debris into areas where there was none before, as can clearly be seen in this publication from Frank Paquet. All the blue material you see here is debris in the isthmus between those canals that was not there before the treatment started. What we would like to see is clean root canals all the way down to the apex. We want a clean, disinfected root canal system without any debris or biofilm left. One step to get closer to this goal is sonication. Two questions you have to ask yourself when you want to introduce new instruments or new methods. First of all, is it dangerous for the tooth or for the patient? And second, is it efficient? Does it work? Otherwise, just forget about it. Sodium hypochlorite is the most popular irrigation solution and it is used from 0.5 to 6% concentration. It is a very potent antimicrobial agent, killing most bacteria instantly on direct contact. The problem is direct contact. Because in vivo, the presence of organic matter, that is inflammatory exudate, tissue remnants, microbial biomass, consumes sodium hypochlorite and weakens its effect. Therefore, continuous irrigation and time are important factors for the effectiveness of sodium hypochlorite. It works only if it actually reaches the bacteria. On the other hand, if sodium hypochlorite is accidentally injected beyond the apex into the periapical tissue, the patient experiences severe pain and possibly permanent damage to his health. Therefore, protective measures have been recommended. Protective measures during sodium hypochlorite irrigation include a waterproof plastic bib to protect the patient's clothing, eye protection for the patient and the operator, and the use of sealed rubber dam for isolation to make sure that the sodium hypochlorite does not get into the patient's mouth. Here is one of my assistants with waterproof protection of her clothing from the barber supplies. Protective measures during sodium hypochlorite irrigation that have been suggested are the use of side-exit Luer-Lock needles for irrigation so the pressure does not go toward the apex but sideways. The irrigation needle should be a minimum of 2 millimeters short of working length. The needle should not bind to the walls of the canal to avoid injecting irrigation solution beyond the apex, and, of course, there should be no excessive pressure during irrigation. On the right side, you can see a picture of a sodium hypochlorite accident where the sodium hypochlorite was accidentally injected into the tissue. If you Google sodium hypochlorite accident, you will find pictures that look much worse and more severe. So the injection of sodium hypochlorite into the tissue has to be avoided. On the other hand, avoiding accidents is also a problem. It is very likely that one of the most neglected procedures in cleaning root canals is irrigation of the most apical part of the root canal, so there's a problem. How can you clean the most apical 2 millimeters, which is the most complicated part of the system, if you have to stay away 2 millimeters from that area? You cannot stay away from it and clean it at the same time. So removing all debris and bacteria and staying away 2 millimeters from the apex is something that seems to be hard to achieve. Our goal has to be to clean and disinfect this apical part without extruding sodium hypochlorite beyond the apex. I think we have to make a difference between contact with tissue and injection of sodium hypochlorite into tissue. Contact, in my opinion, is useful and necessary because the bacteria are only killed at direct contact with sodium hypochlorite. If you do not have contact with sodium hypochlorite, you do not kill the bacteria. If you leave bacteria, you have a problem. There are 3 reasons why I'm convinced that direct contact of sodium hypochlorite with vital tissue is not only useful and necessary, but also harmless. The first reason results from my experience with pulp capping with 6% sodium hypochlorite and MTA, which I adopted from George Bogan of Los Angeles, California. I used 6% sodium hypochlorite, sonicated the solution, which is one little modification of his protocol, and another modification is that I do it in a single visit instead of 2 visits. I've done over 130 pulp caps in Carius dentin with that method, and I have not seen a single necrotic pulp afterwards. There have been a few cases where I had to do a root canal treatment later on because the patient said, "I'm aware of the tooth too often, it doesn't really hurt, but I can feel it quite often at a sub-pain level." Yet there was only 1 acute pulpitis after 10 months and not a single necrotic pulp. Here is a case of a pulp cap with a large exposure of the pulp. I placed white MTA on the exposure after disinfecting the area with sodium hypochlorite, then put Vitribond on and reconstructed the tooth with composite resin. The pulp is a very delicate tissue and, as we all know, can cause severe pain. On the other hand, if the pulp tolerates contact with 6% sodium hypochlorite without causing pain, I see no reason why the apical tissue should not tolerate the contact with sodium hypochlorite without damage. The emphasis is on contact. It must not be injected into the tissue, but the contact is very helpful and necessary. The second reason is my experience with sodium hypochlorite in teeth with a wide open apex. These are a couple of lines from the directions for use of a German 5% sodium hypochlorite product. One of the contraindications, as mentioned here, is an open apical foramen, and there is also a warning that contact of the solution with skin, mucosa, and eyes should be avoided, as well as the intrusion into the periapical tissue. The contact between sodium hypochlorite and bacterially contaminated tissue is necessary and desirable for maximum disinfection for the reasons stated before. Yet, intrusion of the solution into the tissue has to be avoided. More intense contact and better contact of the sodium hypochlorite can be achieved by sonicating the solution. Around the millennium change, there was a lot of discussion about activating sodium hypochlorite in the Roots mail list. This is a worldwide community with more than 20,000 members and now a Facebook group. In those days, it was just a mail list. For lack of adequate tools, I had to improvise. For instance, I held an 08 reamer with a hemostat and touched the hemostat with the tip of an air scaler to make the reamer oscillate in the canal in order to activate the sodium hypochlorite. According to the literature, the penetration depth of sodium hypochlorite into dentine tubules may be up to 300 micrometers.
All of the good clinicians I know use full-strength sodium hypochlorite for all of the reasons I just listed. Now, let's talk about how the evolution of EDI took place.
The idea with the hemostat and the reamer was of course not good for daily practice because I was always lacking one hand when I had to hold the hemostat, the air scaler, and the mirror. I tried to build prototypes that would allow me to do the same job using two hands. One holds the mirror and the other one the air scaler. So I glued nitrile finger spreaders into Sonix's tips with epoxy glue and then activated the air scaler. There are actually two products available today that work on the same principle, the Comate SonicLine SF65 and SonicFlex EndoClean by Cavo. These tips were very effective. In this picture, you can see a plastic block with debris from root canal preparation in it. The next picture shows a clean root canal, but it also shows some problems with the nitrile tips. If we take a closer look, we can see that there is a ledge in the curvature because the nitrile tips are simply too stiff to go around the corner. The root canal is completely clean to the ledge and 1 millimeter beyond, but the rest of the canal still contains a lot of debris. This video shows the action of the commercially available Comate SF65 tip, and you can see that it does move around the corner, but as soon as the tip is beyond the curvature, it stops swinging because the tip is too stiff. When you withdraw it, the swinging action starts again. The speed is set to 10% so the action can be watched easily in the video. When the nitrile tip goes all the way down to the apex, there is practically no motion and you see no foam because the nitrile tip binds to the canal walls and cannot swing. The third problem is the occasional breakage of the tips, and those broken tips are quite hard to remove once in a while. If they are loose in the canal, they can usually just be sucked out with microsuction, but sometimes that does not work. In 2007, the plastic endophile that you can see on the top left came on the market, and I thought that was going to be a great tool for my purpose. I just cut off the handle that goes into the counter-angle handpiece and glued the rest into those air scaler tips. This worked, but unfortunately it was hard to take those tips out after use and it got quite expensive. I experimented with different ideas. I used NSK Varios tips and tried to adjust the diameter of the plastic endophile so it would fit in there, but that turned out to be very difficult with the tools I had. Another option was that I glued those tips into little metal tubes of 1.5 millimeter outside diameter, and those fit exactly into those NSK Varios tips. I found that the air scaler is much more effective with plastic tips than an ultrasonic device. In ultrasonic, the frequency seems to be too high and there is practically no motion. I tried that too, but it did not work well. Here you see a plastic block with debris after root canal preparation, rinsing and microsuction. Rinsing alone cannot effectively remove debris, as you can see. After sonication with the plastic tips, the canal is completely clean. I showed this idea to a small group of endodontically interested dentists in 2009, and Hans-Willi Hermann, who has a blog on root canal topics, which is very popular, more than 1 million clicks, called it the Zeppinator, a new potential device in 2009. He wrote, "Definitely one of those tools we would use most often for every endo case and every appointment. We will love it and never want to give it back. Nothing rinses more effectively than the Zeppinator, and without any negative side effects. No ledges, no fractures of the tip. Would be, would have, as long as the device is only a prototype, there is nothing you could use. So we can only hope that there will soon be a manufacturer that will make the Zeppinator ready for the market." I tried to make my production of the prototypes easier, so the last version I used was an endo chuck that I had modified so 0.8 millimeter plastic tips would fit in there. That worked, and the changing of the tips was fast and easy. But I had to cut off the handle of the tips when I wanted to change one. I presented that idea to VDW with the intention to turn the prototypes into a product. Markus Borgschulte, the head of R&D, had the idea to do it in a different way. Make the tips completely from one piece that you can screw into an air scaler, and you do not have to change tips in the metal device. As you can see, the product that was developed by VDW looks pretty much like the tips I made, only that it is completely made of polyamide. This is what the product, which had the product name Eddy, looks like. You just screw it in by hand until you feel increasing torque. There are also length markers that I suggested that give you control how deep the instrument is introduced into the root canal. It is very important that you make sure the tip of the instrument is in the canal before you activate it. Also, that you deactivate it before you remove it from the canal to avoid fractures of the tip. This is what it looks like in a blister pack. The project name Eddy was also used for the product, which is quite unusual, but describes the action of the tips very well. In German, Eddy is Wirbel or Strudel, and for English speakers, an eddy is defined as a circular movement of water counter to the main current. Eddy is 31 millimeters long, and in some root canals in the back of the mouth, like mesial canals of second molars, it may be difficult to introduce the tip directly into the root canal because the patient cannot open his mouth wide enough. But it is very easy to pre-bend the tip, so it can be introduced into the root canals of every single tooth. Another little tip is to make markers with a felt tip pen when using the Eddy tip in teeth with a wide open apex. You do not want to introduce it beyond the apex, and counting those rings is a little bit of a problem once in a while. The felt tip mark gives you an extra indication when you must not go beyond a certain point.
So, to recap, you screw in Eddy with your fingers just until you feel the torque increase. You can pre-bend Eddy if you need to. Just be careful to avoid sharp bends. Always make sure that the tip's working end is inserted into the canal before the air scaler is activated. And deactivate your Eddy before removing it from the canal to avoid breakage. You never need to put any pressure on Eddy when you have it in the canal. Work with it loose, moving it up and down. Don't get any closer than 1 millimeter to the end of the canal in cases with an open apex. To be safe, you can add a length mark with a felt tip pen on your Eddy tip. Finally, remember that Eddy is sterile right out of the package and should only be used on one patient.
This is a slow motion of a high-speed video that shows how Eddy acts underwater. If you watch closely, you can see little bubbles at the tip from the activation that is caused by Eddy in the water. Also, you can see that there are knots when Eddy swings. At these knots, Eddy does not move much, and therefore there's not a lot of activation in the irrigation solution. To obtain the best results, you should move eddy slightly up and down in the canal while the assistant continuously maneuvers the irrigation solution into the pulp chamber. This is a video at 10% speed that shows how eddy moves in the canal. The apex is open and you can see there is solution coming out from the lateral canals, but nothing at the tip. So there is a little pressure exerted to the sides, but practically no pressure to the apical foramen, which is very important to avoid hypochlorite accidents. In a canal of normal size, eddy's motion is limited by the canal walls and the amplitude is a lot smaller than it would be in the air. That is why you should not activate it in the air. If you activate it in the air at full power, the tip will break within less than 2 seconds. The beginning of this video was at normal speed, and if you slow it down to just 10%, you can see how little pieces of about 2 millimeters fracture when eddy is activated in the air. On the other hand, when you use eddy in a canal that limits the motion and limits the amplitude, as you can see in this video, where I used eddy for more than 6 minutes, the speed of the video is 20 times normal, even after more than 6 minutes, eddy does not fracture because the amplitude of the tip is limited by the canal walls. In case an eddy tip does fracture, as you can see in this transparent tooth, it is very easy to retrieve even in a curved canal like this. We can simply try to get it out with another eddy tip if there is enough room. In case this does not work, take a rotating NiTi file which will pass eddy, and due to the rotation, it will move the fracture tip out of the canal. Another way is to screw a small headstrom file next to eddy and just pull it out with the headstrom file. Another possibility for eddy to break is in very large canals, such as this central incisor after trauma. You can see the canal is more than 1.5 millimeters wide, and the amplitude of eddy gets very big, and it is possible that it fractures, but as you can see in this picture, there are little bubbles attached to the fractured tip of eddy, and it just swims up on the top of the irrigation solution, and it is very easy to remove by suction. One of the great features of eddy is that it can work in very, very curved canals, as you can see in this upper second molar, where the MB2 canal has a severe double curve, which is very hard to follow with NiTi instruments, and the fracture risk is very high. And yet, it was possible to sonicate it all the way down to the apex. This is another example of very curved canals in an upper molar. Now, this is an interesting experiment, eddy working in gummy bear blood, as my friend Holm Reuver called it. He created this experiment, and we did the movie together. He placed some gummy bear gel that had been heated in the microwave between 2 microscope slides about 1 millimeter apart. After it had cooled down and set again, we created a root canal in the middle with a 3504 NiTi instrument, and then eddy was introduced into this root canal for 2 minutes. The video is at double speed. On the left side, you can see how eddy works with the low power setting, and on the right side at full power. You can see that with high power, eddy is way more effective in removing this gummy bear blood from the canal walls. The same applies to necrotic tissue and debris that is removed from canal walls and isthmuses in natural teeth. The higher the intensity, the better the effect. The next video shows the effect of eddy in lateral canals. These lateral canals are just threads of gummy bear blood placed crosswise on a microscope slide. The space in between was filled with liquid glass, and then another microscope slide was placed on top. You can see what happens within 10 seconds, and the next 20 seconds there is more effect, and the longer you use eddy in the canal, the more is removed, as you can expect in natural teeth. This is why it has been suggested that irrigation solutions should be used for a certain amount of time to be effective, yet eddy speeds this up quite a bit. All of these videos are at double speed, 60 seconds now, and in the last video it is more than 2 minutes. You can see that there is quite a bit of gummy bear blood removed from those lateral canals. You can also see that practically nothing happens in front, that is apically, of the tip of Eddie, so there is no risk that Eddie pushes irrigation solution beyond the apex. It is much more effective sideways. This slide compares the effective syringe alone, Endoactivator with its sonic action, IRRISAVE, which is an ultrasonic driven tip, and Eddie in lateral canals with gummy bear blood. You can see that the syringe has very little effect, with even some gummy bear blood left in the main canal. The Endoactivator has little effect in the lateral canals. Passive ultrasonic irrigation seems to have the most effect, especially in the small canals, and Eddie gets very close to the results of passive ultrasonic irrigation. But we have to keep in mind that this is the ideal setup for passive ultrasonic irrigation because the root canal is completely straight, which does not happen very often in natural teeth. As soon as the canal gets a little bit more curved, the effect of passive ultrasonic irrigation will decrease quite a bit because the tip binds to the canal walls and the metal tip cannot swing anymore. This is where Eddie comes into play. Because of its softness, Eddie does not lose its effectiveness in curved canals. In teeth with a normal apex, where there is just patency but the apical foramen is not wide open, I use Eddie all the way down to working length, and in case of an open apex, I stay 1 mm short and make an additional safety marker with a felt pen, which is easily visible while working with Eddie. Thus I can always see how far Eddie is in the root canal, and I do have complete control that I do not go beyond the apex. Let me show you an example. This is a kid with a lateral incisor that has an invagination, also called dens in dente, and the pulp got necrotic at a very early age. The apex is wide open and there is a sinus tract between the lateral incisor and the canine. When you look at the x-ray, you see the dens in the middle and the gutta-percha point pointing to the apex, which is still very wide open. I opened up the tooth, took out the dens, and now you can see all the way down to the apex. There was no mechanical preparation at all, but you can see the apex is really wide open. The foramen is huge, and when using Eddie in there, there is no pressure towards the apex, so I can clean it all out and then place MTA to make an apical plug. Fill the rest up with composite resin and a DT Light fiberglass post. 2 weeks later, the sinus tract was gone, and as you can see, 11 months later, the lesion has completely disappeared. Here is another example. Radix posts are usually easy to retrieve. This is a tooth that had a radix post and had an apicoectomy before. I managed to take the post out without removing the crown. With the help of Eddie, I took out all the old root canal filling material and then filled the root canal with MTA. When you take a close look on the right side, you can see that the lesion has already become a little bit smaller. Normally, a tooth that has had a root canal treatment and an apicoectomy and still causes problem will be extracted, but the patient wanted to try it anyway, and it worked.
I have more than 6,000 canals that I have prepared with the Eddie system since I started developing this tool. Let me show you on an extracted tooth how I work with it and the kind of results we get, and you can get too. This is a very special tooth because Frank Paquet from the University of Zurich did a micro CT scan prior to preparing the root canal as well as afterwards.
This little video shows how I use Eddie. This is an extracted tooth, a lower second molar. I first create the access cavity with a high-speed burr and then open the pulp chamber with a slow-speed burr, create access to the root canals with a discovery burr, and as soon as there is access to the root canals, I can introduce Eddie into the root canal. My assistant rinses the pulp chamber with sodium hypochlorite, holds the suction right next to the tooth, and I activate Eddie to get as much debris and necrotic tissue out as possible. You can see it is quite clean after the first attempt, and I tried to look if there was possibly a third mesial canal. You can see that Eddie does not go far into the root canal because it has not been enlarged yet. The next step is trying to achieve patency. I took an X-ray with size 10 files, checked working length, created a glide path, and then started with an M2 10-4 NiTi instrument to start enlargement of the root canal. Next, I introduce Eddie into the root canal, activate it for 2 to 3 seconds, while my assistant rinses the pulp chamber with sodium hypochlorite and holds the suction next to it to remove excess irrigating solution. I then enlarge the root canal size by size and usually work up to size 3504, and you can see that the Eddie tip is going further down into the canal after each instrument. When I take Eddie out and use the microsuction after sonicating the irrigation solution, we get a very clean tooth, very clean canals. This is what it looks like after completing the preparation. You can see the isthmus and the mesial root that has also been cleaned. Let's have a look at the micro-CTs Dr. Paquet did of this tooth. This is a buccolingual view and also an eccentric view. In the mesial root, there is an isthmus, which you can see after the root canal preparation. When you go down the root, the isthmus disappears and there is an island of dentin in between the buccal and the lingual canal, and then further to the apex, the isthmus reappears. This is what it looked like after root canal preparation. Same views. The red paint marks the areas where radio-opaque material was removed compared to the picture you saw before. There are some untouched parts which are still green, but you can also see where the dentin and debris were removed. In this slide, you can see slices of that tooth before and after preparation. Before is in the top line, after is in the bottom line. You can see that the entire canal and the isthmuses are completely clean, except in the most apical part, in the last millimeter, there's just a little debris left. If you look at it at a higher magnification, you can see some debris in the isthmus before root canal preparation, but after root canal preparation and sonication with Eddie, it is completely clean. This is quite astonishing because usually debris is pushed into the isthmus during root canal preparation, as Frank Paquet showed in one of his published research studies. Look at the picture from his publication on the left side. The material painted blue is debris that was pressed into areas where there was none before. If you look at the top part, the slice of the root canal after preparation, you can see that the isthmus area is much denser than it was before. If, on the other hand, we look at the test tooth that was done with Eddie on the right side, you see there is no debris in the root canal, and the root canal is completely clean and the isthmus is also completely clean. There was also a little reduction of tooth structure in mechanically inaccessible areas, probably due to the effect of hypochlorite and EDTA that were activated by Eddie. If you look at this slide, you see filled lateral canals and a filled isthmus. They are filled with sealer. You have to keep in mind that you can only fill these areas when you clean them out before. Here is another example. A lower central incisor with a very complicated root canal system that cannot be treated mechanically, which can only be cleaned by rinsing and sonicating it. As you can see, the lesion disappeared and it healed very nicely. Here is a lower second molar. There is an isthmus very close to the apex. At first, I overlooked the mesiolingual canal. I had found 2 mesial canals, but the double periodontal ligament looked a little bit unusual. I took an eccentric X-ray, and you can see the files are too eccentric, so there should be another canal there. I did not have a CBCT at that time. This is what the canal looked like before and after I opened it up further to the lingual side, and you can see there is another lingual canal. Root canal treatment was completed, and here is a 1-year follow-up. You can see that there is also a filled isthmus in the very apical part. As mentioned before, you can only fill such an isthmus if you clean it out before and if you do not push any debris into this area during root canal preparation. Now, this is a real wild case. A 35-year-old male with huge caries on the distal side of the first lower molar. Surprisingly enough, he had only very little pain. After taking out the old filling, you can see the tooth is a complete mess. As I have some good experience with pulp capping with sodium hypochlorite, I tried to use it in this case, although it is really a tooth which would normally require root canal treatment. I did the pulp cap with MTA, and the patient had a little bit of pain for 3 days after treatment in the morning. I checked the occlusion and found an early contact. I removed the early contact and there was no pain afterwards. But 10 months later, the patient came back with an acute pulpitis and he was really in pain. When I opened up the tooth, you can see the pulp was still vital when I started the root canal treatment. The post-op X-ray does not look really spectacular, but when you take an eccentric view, you can see there are 3 canals in the mesial root. When you enlarge it, you can also see there is an isthmus in between those 3 canals that was filled with sealer and gutta percha. In this video, we compared the effect of EDDI, Endoactivator, Comet Sonicline SF65, and Irisafe. We were trying to remove dye from the transparent root canal of a transparent tooth, one of those Buchanan teeth, from a 3D printer. You can see EDDI did the cleaning job very fast and very well, whereas the Endoactivator left more dye in the root canal. The SF65 worked effectively too, but if you look closely, you can see that it created a ledge in the curvature. The Irisafe was also effective, but it does not make it around the corner. It could not get past a ledge that was created by the SF65. These ledges cannot be overcome by the Irisafe. The following test was done by Dr. Reinhold Storch from VDW, and I co-evaluated it. He tested how much debris was removed from 3 artificial grooves in 9 teeth for each method, that is, irrigation with syringe, passive ultrasonic irrigation with Irisafe, and EDDI. Possible scores were 0, meaning there was no debris, 1, less than 1/2 of the groove was filled with debris, 2, more than 1/2 of the groove was filled with debris, and 3, the groove was completely filled with debris. Thus, the best possible score for one method would be 0. All of the grooves empty in 9 teeth would be 9 times 0 plus 0 plus 0, yielding 0. The worst possible score, on the other hand, would have been 81, with all grooves full of debris, and would be 9 times 3 plus 3 plus 3. We expected results in between for every method. If you look at the pictures, there are black crosses indicating the evaluation by Dr. Storch and orange comments which I added. Here is one. This is a tooth that was cleaned by syringe. The left picture is before the experiment. You see all 3 grooves are completely filled with debris. On the right side, there is debris left, and according to my judgment, the left groove was completely filled with debris. I judged that the other 2 contained less than 1/2. Reinhold Storch, on the other hand, judged that all 3 were more than halfway filled with debris. This is a tooth that was done with passive ultrasonic irrigation. Reinhold Storch judged that there was no debris left in the grooves. In my opinion, the middle groove contains some debris, and that is why I thought this was a score of 1 for that groove. This tooth was done with Eddie. You can see all 3 grooves are completely clean. Reinhold Storch and I agreed on the score. According to my evaluation, the results were as follows. Irrigation with syringe achieved the worst score of the methods tested with a score of 44. Passive ultrasonic irrigation was a lot better and had a score of 16. Eddie scored best with 1 groove more than halfway filled and 2 grooves filled less than half with debris. All other grooves were completely empty, so the score for Eddie was only 4. This experiment was done by Klaus Neuhaus from the University of Bern, Switzerland. He compared the reduction of colony-forming units of bacteria from canals using manual irrigation, passive ultrasonic irrigation, and Eddie. The irrigation was performed with 0.9% solution of sodium chloride because they wanted to check the irrigation tool and not the irrigation solution. The effect in straight canals and curved canals was quite similar. The picture shows log units of colony-forming units. Syringe alone reduces the colony-forming units by about 90%. Passive ultrasonic irrigation leads to a reduction of approximately 99%, and Eddie yields a reduction of approximately 99.9%. The results were statistically significant. This is a premolar of a patient who had had a root canal treatment started in another practice. It was not yet complete. There was an intermediate dressing in between appointments and the patient was still in pain, so the colleague referred the patient to our practice. This is a picture that was taken right after removing the temporary filling. You can see there is a lot of material in there. To start, I just introduced Eddie into the root canals, rinsed with sodium hypochlorite and activated Eddie. After a few seconds, you can see the canals look completely clean. I did not like the isthmus area, so I opened that up with a discovery burr to be sure I had cleaned that isthmus area out completely. Then I rinsed and sonicated it with Eddie for another few seconds. Compare the pictures before and after. You can see what a difference it makes to sonicate with Eddie. I'm often surprised how fast lesions heal when we sonicate with Eddie and sodium hypochlorite. Here is an example of 2 lower molars that were retreated. You can see there is a pretty big lesion. After only 6 months, most of the lesion was gone. Here is another one. A first lower premolar which probably would have been extracted in 99% of all practices. It was absolutely loose with a pocket all the way down to the apex. I did the root canal treatment, sonicated it with Eddie, which in this case was a prototype. You can see after 14 months the lesion is completely healed. The next one is quite astonishing too. This lower second molar has a huge lesion. I prepared the root canal, sonicated it with Eddie and rinsed with sodium hypochlorite. After only 4 weeks, when I obturated the tooth, you can see that the lesion has already become smaller. Here is another case, a lateral incisor with a through and through lesion. There was no bone, neither on the buccal side nor on the palatal side. The tooth was scheduled for extraction. The patient did not like the idea, so she came to our practice and asked if there might be a chance to save the tooth. I did the root canal treatment, sonicated with Eddie, and you can see after only 4 months, the lesion has become a lot smaller, and another 5 months later, most of the lesion has disappeared. This is a second molar in a 70-year-old patient. He did not have any periodontal problem so far, and all of a sudden, he came in with a massive interradicular bone destruction and a sinus tract, as you can see on the right side. Instead of extracting the tooth, I prepared the access cavity and started root canal treatment with cleaning, shaping, and sonication with Eddie, and sodium hypochlorite and calcium hydroxide as an inter-appointment medication. Surprisingly enough, after only 3 weeks, there was a normal-looking gingiva, no sinus tract, and the furcation also looked very nice. This is 5 months later. Most of the lesion has disappeared, probing depth is normal, and the tooth is fine. The 2-year follow-up shows complete healing.
We have spent most of our time talking about using Eddie for activation of our irrigating solutions, but this tool is actually quite versatile. I do a lot of my root canal treatments in 2 visits, so I regularly use calcium hydroxide as an inter-appointment medicament. Let me show you how Eddie helps me do this.
This little video shows how calcium hydroxide is removed by Eddie and sodium hypochlorite. Eddie was just introduced into the root canals, activated for a few seconds, and then microsuction was used. Even after only a few seconds, most of the calcium hydroxide has been removed from the root canals, but there is still some left in the apical area. As we know from the literature, it can be quite difficult to remove calcium hydroxide from root canals. After round 2, it looked a lot better. The mirror is a little foggy. With a clean mirror, you can see that the root canal system of the C-shaped molar is clean all the way down as far as you can see. The next video shows a lower molar with 4 canals. The mesial canals merge in the apical area, and so do the distal canals. When I put in calcium hydroxide with a syringe, it comes up in the other canal that is merging at the apex. You can see that the calcium hydroxide that is coming up from the adjacent canal is completely white. There is no debris, nothing in the canal. The canal is completely clean. Otherwise, you would push up some debris and remaining substance from the other canal, which would ride on top of the calcium hydroxide. This next video shows the placement of calcium hydroxide with the Lentulo and Eddie. First, I tried to put the calcium hydroxide into the root canal, and now you can see the Lentulo working in the canal and nothing happens. The calcium hydroxide does not move down. You can rotate it as much as you want, but there is no chance to get the calcium hydroxide down to the apex. Now we try with Eddie, and you can see at the beginning, Eddie stops at the ledge, but due to the oscillation, it manages to swing around the corner, around the ledge, and you get the calcium hydroxide all the way down to the apex. This next video shows the removal of an old root canal filling. This is the palatal canal of the first upper molar, which had been filled with AH plus and gutta percha with warm vertical compaction. First of all, I put some eucalyptus oil on top. The use of chloroform is not recommended in Germany. It's very hard to buy. I tried to dissolve the gutta percha with eucalyptus oil. Went into the canal with rotating NiTi instruments, usually M22506, at low torque and low speed. You can see with the solution and the rotating instrument, after the sonication with Eddie, the gutta percha turns into flakes, which can be removed quite easily with a rotating NiTi file. Rinse again, and it gets cleaner every time in just a few seconds. This is sodium hypochlorite. You can see all of those flakes are coming up. Of course, there is still some gutta percha at the bottom. Other flakes are coming up. The most difficult part, of course, is to remove gutta percha on the inside of the curvature down at the apex. Sometimes it cannot be removed completely. There is some residue at the bottom you can see, but all of the rest of the canal is completely clean. Here you can see a transparent tooth. This is a Lentulo with AH+ in an attempt to place the sealer on the canal walls. On the right side, the same thing with Eddy. You can see that Eddy stops at the ledge in the beginning, but then goes around the corner, whereas the Lentulo did not have a chance to go past the ledge. With the Lentulo, the coating on the canal walls seems to be quite thick, and there are also gaps where there is no coating of AH+. On the other hand, with Eddy, it seems to be more homogeneous, and the layer seems to be a lot thinner, just a fine mist of sealer. Here is a real patient case. You can see a little bit of AH+ on the tip of Eddy. This is an oval root canal with an apical split. You can see there is a fine layer of sealer on the canal walls after activating Eddy. Okay, why Eddy? Well, it combines the advantage of the endo activator with that of metal activation tips. It is easy to learn. It works with your air scaler. It does not damage the root, for instance, perforations or ledges, such as metal tips might do. It cleans isthmuses and mechanically inaccessible areas. It takes irrigation solutions to where they are needed and also works in extremely curved canals. It makes placing of calcium hydroxide easy. It also makes the removal of calcium hydroxide easy. It makes coating the canal walls with sealer easy. There is low risk of tip breakage, and in case the tip breaks, it's fairly easy to remove either with a Hedstrom file or a rotating night tie instrument, and sometimes the tip will just swim up on top of the root canal in the pulp chamber. It is a sterile, single-use instrument, and last but not least, there is no risk. It doesn't cost much, and you will notice the benefit immediately the first time you use it.
As I have shown you over the course of this last hour, the Eddy technique can play an important role in increasing your endodontic success. I have shown how easy it is to learn and to add to your irrigation protocol. You'll remember that we also talked about how easily it works with calcium hydroxide placement and removal. I also like to use it to apply sealer to the canal walls. This is a very versatile and safe tool. The precautions are very simple. Apply energy only when the tip is inside the canal. Thanks to its polyamide construction, you can feel confident that the Eddy tip will not cause ledges inside the canal space. You get high performance even in curved canals. In my hands, Eddy is a perfect interaction of effective activation and safety. Thank you for your attention.